Thank you, Kevin. And so Kevin ended by talking about a paradigm change. Are we ready for a paradigm shift? And one of the things that is moving us toward that paradigm shift is the Affordable Care Act. And one of the things that I want to talk about is just some of the core provisions that are in this. There was a fantastic Grand Rounds presentation that was done in October that I want to reference by Rebecca Pierce and Carolyn Quattrocki, both with the state of Maryland, who did an overview, the very detailed overview on what the Affordable Care Act means for Maryland and the exchanges and Medicaid. But for today, I just want to focus the exchanges and Medicaid expansion. So the expansion of insurance is really where the Affordable Care Act, its primary components. There's a lot going on in that law, but these are really the major changes. Health insurance exchanges, many of you probably know, these are required at the state level. They can look a lot of different ways, state-run, federally financed, or a partnership. There's subsidies for low-income people, but essentially these are marketplaces, individual small group market. And then this is looking at more private insurance that is in one general place where people can shop. Of additional note, though, is the Medicaid expansion. Now, this is made optional by the Supreme Court decision at the state level, and I am delighted that Maryland has been absolutely committed from day one that we were going to expand. And so Maryland has not been part of the back and forth, and maybe we will and maybe we won't. And that, I think, is a real source of pride for us. For those who are looking at the financing of that, it starts out initially fully federally financed for the first few years, and then over 6 years, it steps down to about 90% federal financing. And so one of the things that we're looking at is how this will operate nationally. But here in Maryland, this is something that we're looking forward to. 138% is about $15,000 a year for an individual. This is effective January 1. So treatment starts January 1, but open enrollment starts in October of this year. And so there's so much work to be done to really find and enroll people so that we're ready to go and provide care in January. So one of the things, I think we were going to be taking questions in the end, so I'm just, if you can hold until then. So Kevin talked about disparities in health insurance. This is what this looks like when we compare healthcare for the homeless nationally with other health center patients, other low-income, underserved populations, and then generally in the United States population. And you can see the disparities, certainly a disparity in being uninsured for homeless individuals. Again, just the folks that we're serving at HCH projects, this is nearly 500,000 folks that are uninsured. Most of these people will be eligible for Medicaid expansion come 2014 in those states that choose to expand. We know, and this is a public health audience, we know that the poorer you are, the less likely you are to have insurance. It correlates. And the wealthier you are, the more likely you are to have private insurance. It is a misnomer, and I think in the general population, in our political discourse, that just because you are poor, that you are qualified for Medicaid. We specifically have a gap in Medicaid that's been established in federal law that prohibits Medicaid coverage for single non-disabled adults without children. And this is what the Affordable Care Act is going to fix. So when you look at eligibility thresholds, now this is averages across the country, but we do nothing for childless adults. We do something for jobless parents, something for working parents. We tend to do pretty well by children and pregnant women. But again, we have no consistency. And one of the things I think that's also a misnomer is when we say the United States has a healthcare system, we don't really have a system, or if we do, it's not really a very good one. We have a patchwork of healthcare programs that don't do a very good job of coordinating with each other. And we have fragmented care, and actually when we compare ourselves to international colleagues, anyone we'd want to be compared to, our quality outcomes are not as good. So this is the gap that the Affordable Care Act fixes. So currently eligible, generally speaking, we look at children, pregnant women, people who are disabled, and then some parents. What the Affordable Care Act does is it provides at least some common threshold. So you'll see that bar here across we're at least trying to streamline. So those who are newly eligible expands to people earning up to 138% of poverty. So again, I had mentioned $15,000 a year for singles, goes up to about $25,500 for a family of 3. 15 people 15 million people, will be newly eligible again if all states expand. We know the parameters around this in terms of being a U.S. citizen or legal resident. There are a number of states that actually have already gone forward and taken the step to increase their Medicaid programs in full or in part to date, using some options in the Affordable Care Act. But Maryland, again, we're doing open enrollment in October, and we'll go live in January. The Affordable Care Act not only closes the gap in eligibility, but it also makes some real significant improvements in the enrollment process. And one of the things a number of things that we're looking at, electronic verification of income and identity. This is a big, big improvement. If you are homeless, you don't have all of your documents with you all the time. They were either stolen or lost or destroyed in the rain or what have you, but we replace birth certificates every day at Healthcare for the Homeless. You need a birth certificate. You need an identity card. And in a lot of places, you can't get into the Social Security building without an ID. But in order to get a Social Security card, you need an ID. It becomes this almost sadly comic catch-22 on how you get an identification when you have no money. So again, but the thing is that we know electronically how much people make. We know how much, all of us are in the IRS, and even proving lack of income is going to be possible. So electronic verification for our patients is going to be a particular boon. And again, they're going to be matching identity and citizenship through the Social Security Administration. So just knowing your name, your Social Security number, your date of birth is going to be enough. We can electronically verify who you are and how much you make. Using gross income, no more asset tests, no more teasing through whether you have a car, what the value of the car is, all of that. It's enough just to go on what you make. Faster approvals and turnaround times, no in-person interviews. Again, all of the kinds of barriers that traditionally have tripped up lots of populations, but in particular homeless folks. And then online applications, there will be the possibility to do by phone and mail, but we're going to really be streamlining this online. The address is also a big deal. You don't have to prove your residency with paperwork that doesn't exist. Usually we prove where we live by bringing in our mortgage, our rental statement, a utility bill, some piece of mail. But if you have no address, how do you prove that you live in Maryland? And so again, these makes enrollment improvements that will really streamline this process. It puts alternative points of contact. If I'm not reliable to get in touch with, my case manager might be. And putting her on that application really will streamline questions or anything that might come up. Again, these are traditional barriers that the law really makes much better. And when we ask, well, what is it about Medicaid that's going to be so important? Here are 12 reasons, and there's a wealth of information and documentation in the public health literature that goes behind each of these points. I didn't want this to be a full treatise on a literature review, but I think that we're pretty square, and the documentation shows that having a health insurance not only stabilizes your health, it stabilizes your finance. Medicaid has been demonstrated to be good quality care, high patient satisfaction. It's a fairly efficiently run program, not as efficient as Medicare, I might add, which also could be expanded. But when we look at Medicaid itself, these are the real reasons why this is critical for this population. When we look, however, at who is likely to enroll in Medicaid, this is where we start getting into the nitty-gritty of the implementation. And this is where we start balancing risks and opportunities. 15 million people will be newly eligible, but that's only if all states expand. And when you look at the numbers of the Congressional Budget Office, they're only estimating that 7 million people are going to enroll in the first year, and after 2 years, only 10 million people will enroll. Why is that? Well, part of the reason is this. So this map shows the disparities of where states are right now and whether they're saying that they're going to expand Medicaid, whether they might expand Medicaid, whether hell no, they're absolutely not going to expand Medicaid, or whether they just haven't committed yet. Now, this map is constantly changing. This is as of January 10th, but checking back, with advisory.com/Medicaid map, we'll give you an updated version of this as more and more states are making final determinations. A lot of their budget processes and legislative sessions that are going on right now will be making these decisions this year. But here's another reason. Eligibility does not automatically translate into enrollment. What we know about take-up rates for people who were currently eligible for Medicaid, we're still seeing almost 7.5 million adults and children who are currently eligible for Medicaid but are not enrolled. And so again, the barriers to enrollment, the barriers to finding people. One of the things that is really an improvement, the ACA requires states to do outreach procedures to vulnerable populations. There's a whole list here. I've highlighted 4 of the populations that are particularly concentrated in the homeless population. Obviously, homeless youth is its own category, but victims of trauma and abuse, nearly all of the patients that we see have got trauma history. And so again, trauma-informed care and all of that can really be helpful in the delivery of care, but we have to start by finding people and engaging them, because eligibility does not necessarily equal enrollment. So this is what we're looking at in Maryland in particular, and these are the projections that that was done by the Hilltop Institute in July last year. So when we look at people who are going to be becoming newly eligible, we're talking about 90,000 people in the first year, and then moving up from there. We have then, of course, people who are currently eligible but will enroll as part of the woodwork effect, right? So we're going to be doing a lot of advertising and campaigns and outreach and education. And as people are coming into that net, we'll be having 2 populations come: people who are newly eligible, people who are currently eligible. And so the current population in the Medicaid program is projected to really grow. And I think this is a good thing. Now, it certainly raises implementation and administrative challenges, but from the point of view of public health, this can only be a good thing. And so one of the things I'd really like to correct, and one of my pet peeves is when I hear news media or the commentary talking about universal health care. Everyone's going to be covered by insurance. Affordable Care Act is, in particular, socialized insurance, or This law does not establish a right to health care in America, and this law does nothing to establish universal coverage. And I think it's so important. And if I could ask one thing, please, if you hear someone using those global terms, correct them. Because this is what the reality might be. The Congressional Budget Office projections after the Supreme Court decision showed that we are going to remain in 2014 with 41 million people remaining uninsured. 2 years after this bill goes into effect and the exchanges are online and Medicaid expansion is up in states that choose to expand, we will still have 30 million people that remain uninsured in the United States. And I think that this is the story that no one is talking about. What grieves me is the political capital that we are spending, all the blood and sweat and tears that we have put into either fighting or championing the affordable health care. When it comes to solving the problem of an uninsured population, we've only got a glass half full. We have to figure out what is the next step. What is beyond the Affordable Care Act so that we can bring this clear disparity down? The statistics that you're seeing here is an Urban Institute's analysis that showed that of the remaining uninsured, we have a number of people who actually will be eligible but unenrolled. Again, what we know about take-up rates. We know that about 1 in 4 of the uninsured will be undocumented or ineligible immigrants. So thinking through, particularly from a public health standpoint, what is the provision of care for people who are not enrolled in an insurance plan? And it will be a mistake to assume that anyone who is uninsured past 2014 is automatically an undocumented person. So thinking past stereotypes and really looking to the fine-tuned piece of delivering comprehensive care to everyone who needs it is really going to be the challenge. And how do we incorporate real truth into the political discourse that we have going on right now? When we look at the change in percentages just here in Maryland, these are projections. Again, this is the Hilltop Institute in July. But again, Maryland is going to be on average with the United States in that we're reducing our rate of uninsured by half. So again, this is palpable improvement. This is absolutely a step in the right direction. But I think that we really, again, need to be thinking about this law does not solve the problems in our healthcare system, but this makes tremendous gains in addressing them. So just some quick numbers on the remaining uninsured. So when we think about extensions of insurance to particularly very low-income population that is vulnerable, has a number of healthcare conditions that Kevin described, let's think about how do we care for that? So when I said that eligibility doesn't necessarily translate into enrollment, there's another step to that. Enrollment doesn't necessarily translate into engagement and care. And let's think about all three steps. We have to find people, we have to enroll them, we have to engage them in care. And it's that engagement in care is where the magic is going to happen. It does nothing of real substance to carry a Medicaid card if you have no one who's going to see you. And it does nothing to have a Medicaid card and just have that card and not go and see anyone who's going to address the multiplicity of healthcare conditions that you have. That's just enrollment. That's just a card. And at the end of the day, it'd just be a piece of plastic. We need to really think about how we're delivering care, not just to the general population, but really to some of these very acutely ill subpopulations. So how do we integrate care? Right now, Maryland is thinking about how do we integrate our mental health and behavioral health and addiction system, and thinking globally, what does this look like in a coordinated way that includes medical care? How do we focus on quality and outcomes? And really whether people get better, whether they're able to stabilize, whether their health status improves, not just the number of MRIs and the number of procedures that we did. We have to get away from that mindset. This law really tries to turn that boat into a direction of quality and outcome. But again, thinking about what does that really look like in the contractual procedures and how people are reimbursed, and really what are the incentives being built into our new healthcare system. Thinking about patient-centered medical homes, electronic health records, coordinated care. How are we tracking people from hospital to community care, across behavioral health, into inpatient care, into a variety of things, nursing homes, assisted living, step-down units. We have so many different kinds of care, venues of care, but how are we exchanging information? Oh, we may have electronic medical records in an individual provider, but that doesn't necessarily mean that that provider can speak to 10 different other places where you've been and coordinate that data. We're still going to be wrestling with how we exchange information and how we make decisions, clinical decisions and administrative decisions based on data. And then thinking about how we're coming back to the social determinants of health. When we think about the social determinants, housing is clearly present there. Kevin started off by talking about place matters and housing as healthcare. This is fundamentally built into this. So thinking not only just beyond Affordable Care Act, but let's think about beyond simple traditional definitions of what healthcare delivery is. If we are going to be insuring a sick population and that population's living on the street, let's think through what that means absent housing. You can spin somebody through an addiction recovery program that now will be covered through Medicaid, and you can do that 2, 3, 10, 15 times. If someone's being discharged to the street, if someone's still not stable afterwards, well then you've just wasted the investment of treatment 2 and 3 and 5 and 10 and 15 times, and then we wonder why people don't get better. You can spin somebody through the emergency room, and we've got tons of data on this, 185 times in a given year. My dissertation showed the top user of emergency rooms in downtown Baltimore City visited an emergency room 185 times in one calendar year. That is every other day. And at the end of the year, still sick, still homeless. What was the what quality of care was able to be delivered? What's the value of the services that we all contributed to? And at the end of the day, what happened to her? We can do better than this. Again, thinking beyond, what are we ready for a paradigm shift that really includes housing as part of healthcare? So one of the things that I just recommend that we think about when we go forward, particularly because this is a lot of information and a lot of slides here. I'm hoping that you've got those so that you can refer back. Use this information not only in your research, but also in your discussions, family and friends, your community leaders, and all of the conversations and forums that you're in to influence this, thinking about what do we do with this information. We have to ensure that we're targeting outreach. And outreach means a lot of different things to a lot of different people. But we have to think beyond bus ads and billboards and really think about having somebody out there who can beat the bushes. Go under bridges, into the alleyways, into the encampments to find Tony's tent and make sure that Tony's not only outreach, not only enrolled, but engaged in care. So thinking about enrollment, thinking about how we track that. We've suggested that maybe StateStat or some body really measure how are we going to ensure that those at the lowest income groups are being enrolled in Medicaid. And then track the capacity. One of the things that I'm really interested in is, and we're talking a lot about the economy and jobs and all of this in this country right now. It's the #1 issue in the last election. There is nothing about the Affordable Care Act that's not a jobs bill. That was a double negative. Let me say it the other way. The Affordable Care Act is a jobs bill. We act like this money is all, going into thin air to people who, people who either don't deserve it or it's curious the rationale. But at the end of the day, Medicaid payments go to doctors and nurses and medical assistants and a broad range of therapists and social workers. And it's not just the direct care and the direct workers, it's also the indirect workers. Medicaid payments that support places like healthcare for the homeless and other community health centers and a full range of doctors' offices also pay for the woman who answers the phone and the people who do the billing, and then indirectly the people who clean the building and do the wiring and fix the plumbing and come in and do the painting. All of this comes into our local communities. All of this money goes to support local jobs, local economy, local families, and I just really wish and I would urge everyone to try to insert the economic development that healthcare can be for our community. Maryland, and particularly Baltimore, of any place in the country, which has a lot of its economic development and employment base rooted in healthcare, should know this. When we grow our healthcare system, we're also growing our employment base. So thinking about this in a different way. So when we talk about medical and behavioral health service capacity, who's going to be seeing these patients? Who's not only willing to see Medicaid patients, because Medicaid is also, not always the best reimburser, so we have people who are dropping out, but thinking about where are they? Have they been trained in treating poverty as an influencer and how poverty influences health and healthcare utilization, and some curious decisions that we might say, oh, you're just not adherent to medical plan. Well, could it be that this person's sleeping in a shelter or in the street? Do we think to ask? So how is the medical community really willing to serve and then understanding what their services mean? Thinking about MCOs, there's a breadth of services that are going to be needed to achieve cost savings, and that could include housing. There are a number of pilots and some questions that are being asked nationally about how MCOs can incorporate rent or incorporate housing into the plan that they might be able to target toward this high needs population. Again, if you can pay $900 of rent a month for someone who's a high utilizer and you've saved 5 emergency room visits, you've already made that back. So thinking about a broader definition of health. Thinking again about the impact of poverty on health, thinking about services for the remaining uninsured, and how we're pursuing additional insurance expansions. Again, we are not finished with the work to be done on the uninsured, so thinking beyond that. And again, thinking about the states have got a number of options. Medicaid is an incredibly flexible program. Lots of options for states to pursue, to add services, target different populations, and think about how they might be able to achieve the quality and cost outcomes they want to see. That could include Medicaid payments into supported housing. So again, thinking about that and raising those as recommendations. In moving forward and in trying to conclude, there are a number of opportunities that the Affordable Care Act offers us, and particularly this patient population, but there's also a number of risks. We have the real potential here, when we do this meaningfully, to improve individual and public health, to reduce personal bankruptcy and poverty. We have the opportunity to really stabilize people's finances. Increase individual and family stability. If there are people in the audience who are really about the child welfare situation, thinking about how many children are removed and put into out-of-home placements every year because parents struggle with behavioral health conditions. Are those parents insured? Are they engaged in care? How are we really delivering services that we can stabilize families through health care and possibly see some improvements in the child welfare system? Again, just thinking beyond and wider. Again, I come back to employment and productivity. This is certainly going to be a jobs bill, but it's also going to be asking more of the people that we employ. So how is it that we're really balancing productivity and quality of care? Thinking broadly, think about recidivism to criminal justice. If we have people who are going in and out of central booking and America's detention centers and jails every day, we have 12 million people in jails at any given time in the United States of America, many of them with significant behavioral health conditions. If we're treating people in the community, if we have a behavioral health capacity in America's communities that can handle serious mental illness and serious substance use disorders, maybe we can actually stem the tide of behaviors that lead to arrest. Maybe we can reduce recidivism for this population. And from a financial standpoint, every healthcare service that's offered behind the wall is at 100% state expense or local expense in some cases. If we're offering this in the community through an expanded Medicaid population or program, it's at 100% federal expense. States have a real incentive financially here to look at savings from their criminal justice system, particularly their health care, if we can really invest that in our communities and in behavioral health. I think this has got tremendous promise. We actually, I think, have the potential to prevent and end homelessness through better health care if we can do this right and think broadly. But if we don't do it right, and we're not thinking broadly, if we're thinking narrowly, or if we're looking to nickel dime and do that, penny wise, pound foolish kind of policy, which unfortunately characterizes a lot of our healthcare system, if we fail to reach the newly eligible, if we continue the barriers to enrollment, if we're not really investing in providers, if people have difficulty finding someone to treat them or difficulty engaging in care, then we're not going to get there. If we have ongoing housing stability, again, if you're living in a shelter on the street, what's really the incentive to get clean? What's your ability to get clean? Living on the street's real hard, and drugs and alcohol almost make logical sense. If you are going through those kinds of crises in your immediate time, you don't have the supports when you're living on the street to be able to maintain sobriety. That is extremely difficult. So thinking about how we're turning that paradigm shift, like Kevin described, and putting people in housing to be able to address those issues. And then thinking about poor transitions. As people are getting jobs, as people are rising up, Medicaid eligibility is at about minimum wage full-time work. And if you are at $725 at 40 hours a week, that's riding that $15,000 a year line. If you get at McDonald's that nickel or that dime bump, and you're up to $7.50, $7.75, $8 an hour, you've bumped up out of Medicaid and into the exchange. There's a whole workforce here task force here in Maryland that's focused on that continuity of care. How are we transitioning people between Medicaid and the private plans in the exchange that will treat them? What does that look like? The legislative session is planned. I think we have a bill coming up that will talk specifically about how people do that transition. But thinking about that is a real opportunity. It's a risk for a gap, and people falling through the cracks, having treatment disrupted, not being able to find a doctor, and not being able to find a doctor that really understands their conditions or the other life circumstances that they bring to the table. And so we jeopardize that fragile financial upward mobility as people start getting a job and working their way up. If healthcare is going to be the linchpin there, then we risk people really losing that. And the risk, of course, then would be ongoing homelessness. Here's some more information about healthcare for the homeless in Maryland and ways to get in touch with Kevin and I. But I think this has given you an appreciation for where we're coming from caring for a vulnerable population, as well as the risks and opportunities in the law. But I think we've got a number of questions that hopefully have come in. And please put your questions online, because we'll be receiving them here. And I will turn it over to Janie Gordon at this point to facilitate that discussion. Thank you.